Hi, I'm Angela and I'm studying for the Praxis in Speech-Language Pathology, and in this video I will be breaking down the 4 speech subsystems and then the respiratory system's anatomy. That is one of the key topics that it looks like we'll need to know for the Praxis. So there are 4 main speech subsystems that we need to be familiar with in order to really kind of specifically target a client's disordered speech. And it really becomes evident when you're working with somebody who has something like dysarthria, where the different subsystems can be impacted, and then you really need to target those problems in specific order sometimes to help their overall intelligibility. If you're following along on Instagram and TikTok, you should have access to the mini overview posts that I made about the 4 subsystems, as well as some additional notes on the respiratory system. But just to review, they are the respiratory system, then there's the phonatory system that produces the actual voice, the resonatory system, which kind of shapes that voice into its unique qualities and features, and then fourth is the articulatory system, which then shapes the voice into specific speech sounds. So the respiratory system, which we're going to dive into in this video, provides the power behind the speech. So before we even get to producing voice, we kind of have to have that subglottal air pressure built up that's going to flow through the vocal folds and make them vibrate. So if we have a weak respiratory system, we're probably going to end up with some really short phrases where we can only get out a couple words at a time before our voice runs out, or we might have difficulty with our loudness level, among other difficulties non-speech related, such as coordinating our breathing with swallowing, producing a strong cough to keep our airway clear. We kind of just need air, honestly, to live even beyond what we're talking about in our field. So the respiratory system is kind of really important for everything that we're doing. So when we encounter a client who has a weak respiratory system, we're probably going to end up working with another professional like a respiratory therapist, but there's also some interventions like respiratory muscle strength training that we can do to kind of help improve some aspects of respiration for speech or swallowing. So the 2 main actions that we think about when talking about respiration is inspiration, inhalation, which is breathing air into the lungs, and then expiration or exhalation, which is breathing air back out of the lungs. So how does this work? First, we need to understand the concept of Boyle's law, and don't get scared at me. It's not too in-depth, I don't think. I'm going to try to explain it the best way that I can. So we also need to know the difference between alveolar pressure and atmospheric pressure. So alveolar pressure, that's inside your lungs. That's the air pressure that's pushing kind of on the lungs themselves, or the pressure that's in the air in your lungs. And then atmospheric pressure is just the normal air pressure that's outside the lungs that's pressing down on us right now. So Boyle's law basically says that the more pressure there is, the more compressed a gas is going to be. And air, of course, is a gas. It's going to have less volume, it's going to take up less space, and then vice versa. If there's less pressure, the gas will kind of relax a bit and it'll spread out. So think about if you were out with your friends and then you needed to get on an elevator for some reason. So if it's a normal kind of smallish elevator, you'll all just end up standing kind of closer together because the walls are going to cause more pressure on you to stand closer together. But if it was like a big roomy elevator, like if you were at a hospital, then you can spread out a lot more because there's less pressure. And then this is what the lungs kind of do to the air. We have the muscles of inspiration or inhalation that pull on the rib cage and make the lungs have more available space for air. So as it does this, it creates negative pressure, or more empty space inside the lungs. So when you think of negative pressure, think of a pulling force. And so one end of your lungs is open to the atmosphere via the bronchi and the trachea, the part that goes up your neck, out your nose, out your mouth. That part is all open. So the air inside your lungs, when we do this pulling motion, this negative pressure, it doesn't just spread out. It actually ends up forcing air to be pulled into the lungs to fill up the dead space that's in there. And then once more air is pulled in, the pressure ends up switching at some point. So our lungs have expanded from this negative pressure, and then it hits a point where we end up with positive pressure that's going to end up getting pushing the air back out. So the pressure switches from this negative pressure to this positive pressure, which is going to push it right back out. So think of it as each additional molecule of air that goes in is increasing the pressure. So in the elevator, if more and more people are getting on, you're going to get more squished, which is then going to kind of prompt you to get off on the next floor. So as people get off of the elevator, then you're less squished. There's less pressure on you from the additional people who are in there. So that's just kind of how normal resting, quiet breathing works. It uses more of the natural switching between positive and negative pressures and uses mainly just the muscles of inspiration, the primary ones. Your body kind of naturally wants the pressures inside and outside of the lungs to be equal. So you don't usually need to really engage your muscles of expiration or exhalation too much for that normal quiet breathing. But for speech breathing, when you're working out, maybe either bad even, you might need some extra support. So the body can then engage these accessory muscles of inspiration, and then also is really going to engage your muscles of expiration to manually increase how positive or negative that pressure is. It's going to cycle more air in and out of your lungs, and then it can also do a faster rate. So think about your normal breathing. You breathe in until it's comfortable, and then it just kind of falls back out. You don't really have to actively push the air back out. When we're actively pushing the air back out, we're really engaging those muscles of expiration. Now, they might still be involved in that normal breathing, but usually not quite as much as when you're really trying to force the air out. This also, when you think of speech breathing, you have the muscles of inspiration. You have to take a deeper breath, so you really engage the normal muscles of inspiration and then some accessory muscles as well. So you're going and breathing in as quickly and as deeply as you can to get more air, and then you let it back out. So typically per breath cycle of inspiration and expiration, the expiration takes longer. It takes more time to exhale than it does to inhale. This is especially true when we think about speech because we need to take a deep breath, like we talked about, and let it out kind of slowly to be able to make it through our whole utterance. So in this case, it's not just the muscles of expiration, but the muscles of inspiration. They perform something called a checking action. This slows down how fast the air is pushed out of the lungs when you're talking. So think about going down a really steep hill. You're probably going to need to slightly put your brakes on to keep yourself from going way too fast. So we kind of pull back a little bit. We don't stop it completely, but we use some of the oppositional force to kind of slow down what's coming out. Okay, so now I think it's a good point to get into the anatomy. So first, we have the actual lungs themselves, and the right one's bigger and it has 3 lobes, but the left one only has 2 to make room for the heart. The trachea then we have right below your larynx, so right down here, this is your trachea. That's the first part to remember. It's a hollow tube, and it's made up of approximately like 20 cartilaginous rings. It sits right in front of your esophagus, which is why it's important that we have to time our breathing with our swallowing to make sure that the bolus or whatever we swallowed doesn't go down, the wrong pipe and then into the lungs, which we would call aspiration. The trachea branches off into 2 bronchi, so it comes down and then it branches into either lung, and those are called bronchi. That feeds the air into both lungs. Then the bronchi branch off again and form bronchioles. Then those branch further and further and further until they reach the alveoli, which are little air sacs in the lungs that are important for changing over the carbon dioxide and the oxygen. So the lungs sit inside your thoracic cavity, and they're surrounded by the thoracic cage. So that's your rib cage. We have 12 pairs of ribs that wrap around from your vertebra or your backbones to the sternum, which is your chest bone. So the first 7 ribs connect right to your sternum's manubrium. That's the very top portion. I actually have a little model human here who is not constructed super well. So if he falls apart, I'm very sorry. But, ooh, maybe his head is falling off. Let's see if we can get that back on. Oh no, poor Bob. Okay, there we go. So this is Bob. He's going to kind of help us out and demonstrate a couple things. And, I'm actually going to get rid of some of this that's going to get in the way. I'm just going to take out some of these. Okay, so you see down here we have his spinal column, and then the ribs. Oh no, that's okay. I'm going to turn him around. You can see his spinal column and the ribs connect back there. Then we get back to the front and the ribs come around and they attach to the sternum. So I'm going to take this off and hold it up here. You can see this sternum right here. This very top part, it's kind of a little circle. That's the manubrium. Then this middle portion is the corpus, and the bottom is called the xiphoid process. It's typically cartilaginous. So the ribs kind of wrap around, and then the very front portions of ribs through rib number 7 should be cartilage right in the front. Those are the costal cartilages. So that all connects together, and then combined with the back part of the ribs, you end up forming your rib cage. So the very last two paired ribs, which you can kind of see right on the bottom, the last two don't actually connect to anything. Well, they connect in the back, but they don't connect all the way around the front in the whole thoracic cage. But that is your thoracic cage that the lungs sit inside. So between that thoracic cage then and the lungs themselves, there's something called the pleural space, and it kind of lets the lungs glide a little bit, but it kind of keeps them also suctioned to that thoracic cage so that they're not collapsing on us, because that would be very dangerous. So the muscles of inspiration then are going to pull the ribs up and out and create more space in the thoracic cavity and in the lungs. And then the muscles of expiration are going to pull the ribs back down and back in and apply the positive pressure to the lungs to get the air pushed back out. So on Bob, it's going to kind of look like this. So I'm going to turn him this way. Hold that so he doesn't fall apart. So the rib cage is going to go up and out. That's okay. Up and out. And the lungs will expand. And then it'll push back in and compress the rib or the lungs. It's not usually that exaggerated, obviously. You can kind of see on yourself when that happens. But for the sake of this, that's kind of the movement that it does. It's kind of like, kind of like that. In, air goes in, air goes pushed back out. Air goes pushed in, pulled in, pushed back out. Okay, so what are some of the top muscles that we should probably remember when we're thinking about respiration? First, I always think of the diaphragm, and then second, the intercostal muscles. So the diaphragm, which actually kind of fell out, it's this little, it's kind of like a sheet, and it's normally kind of positioned like that with a central tendon right in the middle. This diaphragm is a big sheet of muscle, and it makes up the whole floor of the thoracic cavity. It has that large central tendon that's going to pull down to increase the space in the thoracic cavity for inhaling, inspiration, and then it's going to push back up to decrease the space for expiration or exhalation. So if you've ever made one of those cup launchers where you kind of attach part of a balloon to the bottom of a cup, so you cut off the bottom of the cup, put part of a balloon down there and tie it, that's similar to the diaphragm. So you normally put like a cotton ball or something in there, and then you pull the tie part down, and then the amount of space in the cup is bigger. If you were to look inside, there's more room in there. Then you release it, and you can kind of fling the cotton ball out of it because the positive pressure when that was released pushes the cotton ball up. So that is the diaphragm in a nutshell. That's essentially what it does. It's like dome-shaped, and then it flattens out to make some room, and then it turns back into a dome shape. Moving on to the intercostal muscles, there are three main kinds. There are external, internal, and an innermost. And usually like the internal and the innermost, it seems to me like those are linked a lot of times, just in notes and studying. So the external intercostals expand the rib cage. They pull it up and out like we saw in this. They're going to do this motion, this up and And the internal and the innermost intercostals are going to pull it down and then compress the rib cage. So also kind of pushing it in like side to side like that. So I remember this by thinking about how they start with opposite letters. So inspiration starts with an I, and it's helped by the external intercostals, which starts with an E. And then the opposite, we have expiration, which starts with an E, and then internal or innermost is starting with an I. So it's always an E and an I with intercostal muscles, and then that's kind of just a good guide that's helped me to kind of remember which intercostal does what. So if you're looking at the page of notes that I put in there and the diagram, it kind of breaks it down half and half of some of the muscles of inspiration and some of the muscles of expiration. This isn't really an exhaustive list, but it is what seemed to be highlighted in the advanced review book that I've been using. So that's kind of what I'm going off of. So for inspiratory muscles, we talked about the diaphragm, but we also have the serratus posterior superior, the levator castrum brevis and longus, which are not on the diagram, but I'll show you here. Those go kind of on either side of this. So on either side of the sternum and come down. And then there's a longer version and a shorter version of them that go kind of along there. You have the external intercostals, which we talked about, and then the sternocleidomastoid. There's a series of a couple muscles in the neck that can also help with inspiration. So like if you think about it, like you really breathe in, you can kind of see my sternocleidomastoid, which would be right here, kind of going so. And you can see that kind of trying to help to lift up my clavicle from the sternum area and then raise the rib cage. You also have the scalenes, which are another muscle in the neck that kind of comes down here and attaches. And then your trapezius muscle can actually help as well. You also have the pectoralis major and the pectoralis minor that can help to expand the rib cage this way, kind of pull it open like that. And then the serratus anterior, which is on the sides of your rib cage. So on here, get this off so we can see it. On here, it would be kind of around here. It's kind of on the sides of the rib cage going up and connecting to the clavicle, I believe. Then you have the levator scapulae, which will increase the scapula. So like really just trying to lift all of that up. And then your rhomboid muscles, which are in the back. Okay, then for expiratory muscles, we have the internal and innermost intercostals, which we discussed. The external and internal obliques, we start to get in some of the abdominal muscles, which are going to help really compress that space, because you think of like clenching your abdomen in, it's going to decrease the space all the way up. It's going to push up on the lungs to get some air out. So you have your external and internal obliques, which are on the sides. The rectus abdominis is the one that comes straight down. It actually attaches partly to the ribcage and comes all the way down. And then the serratus posterior inferior, which is on your back, kind of looks like the ones that are on the sides of the ribs, but it's just more to the back. You have your transversus thoracis, which kind of goes all the way around. It's sort of on the inside of the rib cage, and it goes around and forms kind of like a cavity around here, like a layer. And then the latissimus dorsi, which are your lats in your back. Your transversus abdominis, which is similar to like the transversus thoracis, except it goes around the abdomen. And then the quadratus lumborum, which is in your lower back. So we made it through the anatomy overview. Now, we're going to get into the different capacities and the volumes that are used to describe the air in the lungs. And first, we need to remember that normal, quiet breathing is referred to as tidal breathing. Because tides on a beach, it just kind of comes and goes regularly, about 12 to 18 times per minute or so. It's not intense. It's kind of just like the baseline breathing that we already talked about, just kind of like what you'd normally do at any given moment. So the amount of air that we exchange during tidal breathing is just called the tidal volume, which goes along with tidal Remember, tidal, like waves, our normal wave rhythm pattern of our breathing cycle, tidal volume. We have a total lung capacity. That's just how much air could possibly fill in our lungs. So if you have like a balloon, filling that to its max capacity before it bursts, that's as much air as you can possibly fit in there. That is the total lung capacity. But then when we breathe, typically we're not really filling our lungs that much. We're not filling them all the way up and then exhaling everything out. There's still more that we could inhale and exhale. So when we breathe in normally, there's all of this room that could still be filled up. This is called the inspiratory reserve volume, which you can hit that if you breathe in super hard. You can get way up there with as much air as you can possibly take in. When we add the tidal volume and the inspiratory reserve volume together, we end up getting the total inspiratory capacity. So that's all the air that could possibly breathe in after you exhale. So if you exhale, the amount of air that you could possibly breathe in then is the total inspiratory capacity. When we exhale then, the amount of air that could still be exhaled just after a normal exhalation is called the expiratory reserve volume. It's important to know you can't actually breathe out all of the air in your lungs. There's always a residual volume that is going to be there. So when we talk about expiratory reserve volume, it's not all of the air that's left in the lungs. It's just what we can still breathe out of what is left in the lungs. So the total amount of air left in the lungs after normal tidal expiration is the functional residual capacity. So this is on top of what you can exhale. So you can exhale, there's still air left in there, which is called your residual volume. If you breathe out to that point and then count that amount of air that you just breathed out plus that reserve volume, that would be your functional residual capacity, which is a combination of, again, expiratory reserve volume and residual volume. One final capacity to remember is vital capacity. That is all of the air that we can work with in the lungs. So it's your biggest breath in to your biggest breath out. It's everything except for the residual volume. Okay, so that's it for now. We did it, we made it. And if you have any questions, feel free to drop a comment below. But I mean, always just remember, I'm a student right along with you guys, so any information that I give is subject to being accurate because I am learning right along with you guys. I do try my best to research everything and give the most accurate information that I can. But if there's information that you disagree with, please let me know that too, because I obviously want to do well in the praxis, so I am very open to opportunities for growth in my knowledge. Anyways, stay tuned for next week's video, which is going to cover the phonatory system and possibly the resonatory system as well. And if you're studying along with me, hit subscribe and say hi in the comments. Let's conquer this exam together, and then let me know below any topics you'd like me to cover. Thanks.